Okay. Good afternoon, everyone. I'm Bence Halpern. I'm a PhD student at the Netherlands Cancer Institute, University of Amsterdam, and also a guest researcher at the Delft University of Technology. So today I'm going to talk about the work I've done in the TAPAS project, titled Predicting and Synthesizing Plausible Speech Examples of the Cancer Treatment. So I think let's get started with talking about it. Yeah. So today I will address these points mainly. So the first is, why do we want to synthesize plausible speech examples at all? Then I will go into explaining what are the challenges of pathological speech synthesis. And in the presentation, I'm going to talk about two main approaches: voice conversion based approaches and articulatory synthesis approaches to synthesize pathological speech. Then I'm going to wrap up with what I think are the current challenges of pathological synthesis and what are like potential ways to step forward. So first, why pathological speech synthesis? And there are two main reasons. First is, patients currently face large uncertainty regarding their speech outcomes during oral cancer treatment or after oral cancer surgery. So what we want to show them is the future voice, because studies seem to indicate that the quality and amount of information that they receive is insufficient during the treatment, which in turn affects how the quality of life will turn out to be after surgery. We want to improve this, therefore we need pathological speech synthesis. The second is that pathological speech could be actually a useful tool for improving ASRs using automatic speech recognition using data augmentation. So pathological speech has many challenges. I would categorize the challenges into two different aspects. The first aspect is the methodological aspect. Pathological speech is low resourced. There is a low intake of patients which we can collect data from, and patients can decide to not enroll. With the voice conversion approaches that we will see later in this presentation, there is this additional shortcoming that in order to get natural speech or better pathological speech, we would need parallel training data, but that's even more difficult to collect than some data, because 50% of oral cancer patients drop out during the data collection, and we also need to wait a lot of time between these two data collections in order for the voice to sort of stabilize. That means that collecting such a data is quite challenging. The second aspect, which is challenging, is the evaluation aspect. In a previous study, we have shown that actually the naturalness evaluations, which are used in speech synthesis to evaluate the quality of the synthesized pathological speech, is affected by the severity of the pathological speech. And that's a problem, because we are not sure what we are measuring. Sometimes is it the naturalness or is it the severity of the speech? Second, in certain speech pathologies, we have something called the loss of voice identity. And in voice conversion, what we also do is try to quantify whether the synthesized speech sounds similar to the speaker that we want to synthesize. I will demonstrate this in the next slide, but basically the idea is that even if we have a normal speech sample and a pathological speech sample, then we would have a problem of a listener not being able to know whether the speech sample comes from the same speaker. So even if we have the perfect VC system, we would have sort of a difficulty in figuring out whether we have managed to achieve good speaker similarity. So first, I'm going to talk about the voice conversion out of the two big set of approaches today. In this study, because we had a lack of oral cancer data at this time, we decided to make a system on dysarthric speech, so normal to dysarthric voice conversion, with three goals in mind. The first goal is that the user should be able to say any arbitrary utterance. The second goal is that the voice conversion system should retain the speaker identity. And the third goal is that the intelligibility should be reduced and the severity increased during the conversion process. And the two last goals are somewhat contrary to most voice conversion setups. So it's important to emphasize this. There are two previous works that I want to mention related to this. The first one is the work that I have done at IDEA, which was sort of the first attempt at doing this problem. And we used a cyclogram plus T-solar approach to achieve pathological speech. But what we have discovered is that the cyclogram cannot really handle the time variant characteristics of the speech well. So we needed this T-solar vocoder to slow down the speech rate of the speakers in order to match better the characteristics of the dysarthric speakers. And therefore, sometimes the voice quality was not good, and it was also difficult to assess this perspective subjectively because the nationalness and severity perspectives were entangled together, and we needed objective evaluation approaches to show whether the severity and the naturalness works good enough. In other work, for this reason, we try to take a slightly different approach. And the idea of that approach is that let's not think about the pathological speech synthesis for a second, because we could use existing pathological speech samples from a voice bank. And what we could do for the patients is to simply adapt those pathological speech samples to their new voices. And this setup actually worked quite well and was sort of advantageous because only the time invariant structure of the speech, the speaker specific part needed to be changed. And the system still had the disadvantage that you need a voice bank, you need a set of sentences that are already there from a different dysarthric speaker, and you don't have the ability to synthesize any arbitrary utterance. And this system also had the advantage that the problems with speaker similarity and naturalness evaluations applied less to here. It was more the naturalness which was affecting this system. So therefore, in our most recent work, we have thought about combining sort of these two approaches in a way that we can sort of get around the requirement for a voice bank, the requirement to have utterances for approach. And what we do basically is in the first stage, we use a sequence-to-sequence model which the voice transformer network. And in that stage, we feed a healthy utterance as input, and we get a pathological utterance in the speech of a model speaker, which can be set up in a parallel way. And because it's set up in a parallel way, it can give better naturalness results. And then after that first stage, we can convert that using a non-parallel framework to a new speaker's identity. So again, the idea is in the first stage, we can take in an arbitrary utterance, we can make that arbitrary utterance pathological using a sequence-to-sequence model. But in that first stage, the speaker identity of the speaker, that the voice identity of the speaker is lost. Therefore, we want to get back the voice identity so that it sounds normal, but with pathological intelligibility. And we evaluated this tree system on three separate aspects. The first aspect is the nationalness aspect. The second aspect is the speaker identity. And the third aspect is whether the speech is severe. So whether the speech mimics the pathological characteristics of the speech. So in the nationalness evaluations, consistent with our previous results, we still found that during the mean opinion score evaluations, if the listeners are presented to more severe or less intelligible examples of the speakers, even in the ground truth case, they rated them as less natural. So that seems to be a general phenomena when rating pathological speech utterances. But overall, we achieved good natural results compared to the ground truth, but the difference was still significant. So what's also worth mentioning is that compared to our previous work, we had a slight increase in the mean opinion scores, although the two setups are not directly comparable, but that also gives us the idea that we have sort of gone into the right direction with this setup. With the speaker similarity experiments, we had these results where the listeners did not really think that it sounded like the target speaker, and also did not really think that it sounded like the source discharging speaker. And there are two reasons for this. The first reason is that we had imperfect VC modeling. That would be the most obvious reason. But what we also see from the table, which is indicated by the arrow on the table, is that as we choose more intelligible speakers for the evaluation, the similarity to target speaker results get better. So what also happens is probably the problem that I mentioned in the first set of slides, is that there is an post speaker identity evaluation problem when the listeners hear an intelligible and a non-intelligible utterance for the same speaker. They are less able to determine whether it's the same speaker or it's a different speaker. For the severity, we have decided to two different approaches, an objective approach and a subjective approach. The objective approach used p-story, which was basically shown to perform well on this dischargic database in predicting the severity aspects of the speech. We have also observed that here the p-story and the p-story managed to produce similar numbers as in the case of the reference samples. So we thought that's encouraging from the objective perspective. From the subjective perspective, we have decided to design an A/B test with three speech language pathologists who needed to differentiate whether basically which pathological speaker sounds more severe by comparing pairs of ground truth and pairs of synthesized samples. And in that setup, we have also seen that the SLPs could differentiate between the low severity and mid severity and the mid severity of at high sensitivity samples, almost always above the chance level. So that in short, that shows that there is architecture could achieve a good control of the severity aspects of our speech, in our opinion. So I'm going to show just one set of samples so that you have a better idea of what's going on. So basically in the setup, yes, this is the input speech that goes on.
Command.
So this is the healthy speech on which we can take as the arbitrary utterance, and we pass it through the voice transformer network stage. Sorry, may I ask if you hear the sound? Okay.
Command.
Do you hear the sound that I'm playing?
Yes.
Okay. And then after passing through the voice transformer network,
Command.
So we get to this male speaker with high severity, which you can certainly hear the vocoder artifacts on this, but apart from that, it sounds like a natural but severe sample. And this gets converted with the VA model back to the identity of the female speaker. So this certainly sounds less natural, but the idea here is now you hear that we have moved from the male speaker identity back to the female speaker identity. And this is the reference.
Command. Command.
Okay. So the logical question is, can we get better than this? And there are two main obstacles towards getting better, in my opinion. First is that the used data set that we have is quite limited and not ideal for voice conversion. So I think the obvious way to improve would be improving on the data side. The UA speech contains mostly word-level utterances, and not a lot of them. And word-level utterances are usually not the kind of utterances voice conversion is designed for. It would be better to have sentence-level utterances. The another aspect, which is I think worth mentioning, sort of also for one of the takeaways for this presentation, is that better non-parallel voice conversion would need also better automatic speech recognition. And because as from the figure you can see, these are the results from the voice conversion challenge, which sort of compare all the voice conversion models on the same voice conversion task. We can see that voice conversion models which incorporate an element of ASR in their architectures usually lead to speech that's more natural in the non-parallel paradigm. But the problem is that we also suffer from a pathological ASR problem. Therefore, basically, it's sort of a deadlock. One of the reasons, because pathological speech synthesis non-parallel pathological speech synthesis can't better, is because pathological ASR needs to be better. So that's what I wanted to say regarding the results in this paper. And now I want to show the second approach that we tried, which is the articulatory synthesis approach. So what's the problem with voice conversion approaches? Generally, in a clinical environment, what we would prefer is having something a bit more explainable. The idea is that, for example, with an articulatory synthesis model, which could take on some biophysical variable of the articulation and create speech, we could sort of design a biomechanical model that could provide these articulatory trajectories for us, which is dependent on the surgery. And so the idea is that we could predict better, we could predict what kind of surgery brings us the best functional outcomes, the best voice outcomes from the surgery. And basically we could iterate on this process until we find a surgery which is effective for saving the patient, but also is most generous in terms of finding the best speech quality. And that's nice. The disadvantage of this method is that the required data is difficult to collect, but still we decided to collect normal cancer corpus, which contains healthy speech and oral cancer speech, and do articulatory speech synthesis using this corpus. Using an articulatory synthesis framework, and basically we were interested in the possibilities with the possible things we can do with this articulatory synthesis framework. So first, we are interested in the naturalness aspects of the synthesized speech, but we are also interested whether we can actually do this thing, which is to manipulate the articulatory trajectories slightly to get a slightly different speech. I'm going to show an example of what I mean with this. So to have a better picture of like what's articulatory synthesis, basically so in articulatory synthesis, we feed multiple of these MR trajectories into a neural network, which then gives us speech. And the idea would be is that we could make modifications on these articulatory trajectories to see how will that affect the pathological speech. So here you hear that this is just basically showing a recording. So this is showing a recording how the punctive trajectory moves and along with the ground truth speech. In the second case, what you can see is that we have a very similar sentence as the sentence that we have during the training of our articulatory synthesis method, but we just change one phoneme in this testing scenario, and we basically manipulate these articulatory trajectories, and we are interested whether that result in a sound that corresponds to the kind of change that we want to make. In that case, this is a beat, so we are moving from bass to beat, and you can see that the middle of the trajectory sort of differs, and because it differs, we hear a different sound, so it moves away from bass to beat. Okay. So regarding the naturalness results of our framework, we have again here we have found that naturalness is affected by the speech severity, which is shown by the yellow numbers. Another thing that we found is that actually it's not the pathologicalness that again is the problem with here achieving natural speech synthesis, because in the predicted when rating the predicted synthesized synthesis, we found that actually there is not a big difference in the naturalness of the healthy and the pathological ones of the method, which means that the method is more limited by the amount of data available for this method. The second thing is that we found that when we evaluate the articulatory synthesis framework in this manipulation scenario instead of the synthesis scenario, we are able to get better results. So in general, in order to get speech that's better to listen to, we would encourage making rather small modifications to existing sentences rather than creating whole new sentences using this neural network. And we have also run some perceptual experiments, which I'm very much running out of time, so I'm not going to go into very much detail. But the idea is that we found that the articulatory synthesis produces problems in the consonants and also in the vowels, which are sort of the same as in ground truth speech. So it's not only that the synthesized speech, how to put it, so it's not only that the synthesized speech is modified so that the sound sounds unnatural, but it sounds unnatural in the way that it's pathological. It's usually the same things that are wrong in the synthesis that are also wrong in the ground truth, or not really wrong, but mispronounced is, I think, the better word here. So to sum up, evaluation of pathological speech synthesis is not straightforward. Both objective and subjective tests have their shortcomings, and automatic approaches would be needed that work more robustly in order to better quantify where are we with pathological speech synthesis. And there are certain ideas that could bring us there also on the subjective part, where we could test with family members or real patients because they would be able to judge better the quality of these recordings. Also, data scarcity is a big issue in pathological speech synthesis. In the case of the articulatory synthesis framework, speaker-independent articulatory synthesis could be one way to provide more data, and using more modalities would be another way. For example, not using only EMA, but also using MRI or UTI to overall get more data instead of asking patients to produce more hours of data. Yes, that's all I think, and thank you for listening to me. I'm happy to answer your questions if you have some.
Thank you, Bence. I have a question on the experts that judge the naturalness and intelligibility. Were there like a protocol to judge that, or for the naturalness of the speech?
So in the case of the voice conversion approach, or in the case of the articulatory synthesis approach?
Both.
Both, okay. So when judging naturalness, we usually use a text that's also used with the standard naturalness evaluation. So that's the same thing. The only modification we made is to use a 7-point scale instead of a 5-point scale. And the reason for that is that we received some feedback that in this case it would be better to do that, because we are testing with a lot of different severities of speech in the same time. And in that case, you could have like a flooring effect when you cannot differentiate speeches very well because there is not enough points in the scale. When evaluating the severity with the speech language pathologist, it was a very simple A/B task. They have to decide which is more severe, and we didn't have like any specific like text for that. If that's the question, and I'm wondering if in the articulatory there is something, but no. So in this case, we asked the SLPs to basically which one do they perceive more severe, and they were presented multiple combinations of synthesized and non-synthesized in an A/B test setup. Does that answer the question?
Yes. Were they therapists that judge?
Yeah, 3 speech language pathologists, okay. All of them. Yeah.
Hi, Ben. Thanks for the talk. I have one question about your final conclusion slide. I probably didn't get the message clear. So when you say evaluation on downstream data augmentation tasks, speech does not have to be convincing for data augmentation. What do you mean by convincing here?
Yeah, so that's so basically what I told here is just 2 ideas on how you can evaluate pathological speech synthesis, because that's what I still see as like the biggest problem, because even because a good objective evaluation depends on a good subjective evaluation, and we don't really have a good subjective evaluation, in my opinion. And downstream data augmentation is something that we considered at some point that could be used. But in multiple different works, I have the notion that I have seen that actually you don't have to synthesize very natural speech and just add it to data augmentation experiments to work. So even if it captures one particular aspect of the variety in the pathological speech, that can mean that how to put it, that the speech synthesis that the ASR gets better. So I think a good example for this would be how time stretching improves automatic speech recognition in the case of dysarthric speech. Time stretching a speech signal doesn't usually sound convincing, in my opinion, doesn't sound natural, but we almost always find that it's something that helps dysarthric speech recognition. Does that answer the question?
Yeah, that sounds okay. That's good. Thank you about this. So if I understand, your point is valid about how to do pathological speech evaluation, because but then you say one factor, emulating one factor, you're saying is good enough, but clinician may be looking at different factors, right? So how would you decide that which factor was gone into the evaluation? Yeah.
Yeah, that's a good question. What we do is what we did, and what I try to do in many of my works is to do multiple evaluations always to make sure that we are really measuring the thing that we want. So in the voice conversion work, this was using the PS story and the P story, and also using subjective evaluations with the speech and language pathologies to show that it is the severity. There are certain cases where it was more straightforward that it's the naturalness that's being measured. So in the case of Mark's work, which was here, we converted dysarthric speech to dysarthric speech. So in that case, it's more straightforward that the reduction happens because of the naturalness decrease, and not because it's for example a different dysarthric speaker with a different severity or something like that. Because in that case, when you compare to like the naturalness source of the another dysarthric speaker, sure, that's also going to be affected by the severity. But here we try to match the severity during the conversion, which means that both are affected by the severity in the same way. I'm not explaining it very well, but maybe that's answer to the question.
Yeah, that's good. Thank you, Bence.
Yeah. Are there any other questions?
Okay, so if there are no more questions, I would like to thank you, Bence, for your interesting presentation. And thank you everyone for your interest in the webinars, and see you soon, I guess, for next TAPAS events. Bye-bye.
Bye. Thank you, Julie. Thank you, Bence. Bye, Rob, and all. Bye.
Bye.